webinar. And as you know, WeCare is a support group for cancer patients, helping them in their spiritual needs, in their psychological needs, in their financial needs, and whatever we can do. And also before cancer, if you can create enough awareness, then that's the idea that, we must make public aware of the cancer and also make people aware of and cancer patients aware of what they can get and what they can do. So I have two very good persons with me, each one more qualified than the other. But I presume that Dr. Gupta is older than Dr. Watve. So I will take the thing of introducing Dr. Rajendra Gupta first. He's a public policy expert and nearly 2 decades of work in shaping policies which will help all people. So, I keep saying cancer patients because we keep working with cancer, but I know he's working with all health issues altogether. And he has been a part of the National Health Program, and he has helped in formulating some policies in 2017. And then he is also recognized for his contribution across the world, and also WHO and London School of Tropical Medicines. And it's a huge achievement that he has done in his years of work and service. And I know he's totally dedicated to the whole thing. So I'm not reading out the whole, details about you, Doctor, because I know it's going to take us more than 10 minutes to read and tell people about you. So I would like you to add on if I miss out something. And Dr. Watve is from Belgaum. And sorry, I keep saying Belgaum. He is from Kolhapur. And he's the consultant head neck oncosurgeon and medical director at Kolhapur Cancer Center. And one request from Jyoti during her trip to Kolhapur helped us in getting him to be a partner with us for this program. And so thank you very much, Dr. Watve, for that. He has done most of his studies from colleges in Mumbai, like the Sage GS Medical College and KM Medical College and TN Medical College and BY. I think every doctor in the country has, if he has studied in Mumbai, has gone through all these prestigious institutions. And I'm sure they have a lot to offer to each one of you because each one of you is more brilliant than the other. And then he was in Hyderabad at the American Cancer Hospital. And then he finished his head and neck oncology in 2015. I was wondering, it talks about everything. It talks about your being abroad. It talks about you being in Hyderabad. But, it's only in the last paragraph I saw that, he's also been to Tata Memorial. Because every doctor is like, has to be in Tata Memorial. And he worked here for some time. And then, of course, I think home called him. And then he rushed off to Kolhapur to be with the patients over there, which I think is an excellent idea. Because if the doctors are good and if they can go back to their hometown, imagine the respite that they bring to their own patients. And I'm sure Dr. Gupta will agree with me in the whole issue. Because Dr. Gupta, I know for a long time, and I know that he wants as many patients to be helped out as possible. So our topic today is being healthy in the digital world. So before I start anything else, I would like Dr. Gupta to tell us what does he mean by digital world and what does health in the digital world mean to him?
So Vandaji, firstly, thank you so much for having us on this interactive discussion. And I'm really impressed by Dr. Parag. The fact that very few doctors who study in such, aspirational medical college like in Bombay go back to their hometowns. This is very rare to see. I think he's probably the second doctor I know of, because you always move for a better place and a better life. And mostly for such trained surgeons, it is abroad most of the time. But when you go back to your hometown, you actually mean that you wanted to be in healthcare in real sense. I think you're going to be a role model for many more to come, when you look back. And I'm sure not only that you will serve the patients in Kolhapur, but also get people in that region healthier. Hats off to you. And I'm really lucky to be sharing this screen with you. And on the digital health, I think this has been a long journey. We have changed the terms also with time. It started with something called the ICTs, then e-health, telemedicine, virtual care, telecare. But overall, over a period of time, the consensus has been to use the term digital health. And if I were to tell you in one line what is digital health, using technologies to deliver care is broadly what I consider as digital health, which would mean using a WhatsApp or a phone or like a consultation on Zoom, or even using advanced technologies like artificial intelligence and machine learning. So it's a very broad term. But today, if I were to say one word, the importance of digital health for health, I would say if you are not in digital health, you're not in health. That's what is the line that I coined, and I still believe in it, that the world is changing. And this is time where patients are asking doctors that is there any way we can connect back with you once we are back home, or if there is a need. So I think this time the revolution is driven by patients' needs and equally from the doctor's side. So digital health today is integral to care delivery, whether it is primary, secondary, or tertiary. So for me, digital health is a very broad term, but an integral part of healthcare delivery in today's world.
So, Dr. Watve, you must have seen that COVID has been one of the biggest influencers of digital health. It's been both positive and negative, because we've seen n number of messages coming on, as you said, on WhatsApp, about which were mostly, most of the time we found that those messages were not correct and that they should not have been believed. At the same time, there have been telemedicine, teleconsultations, and Zoom meetings. We ourselves have done so many Zoom meetings on various subjects, which will help the cancer patients to understand, and if they need anything, to connect them to the doctors and all that. So what do you think? Has the face of health changed because of teleconsultation?
So yeah, before answering that, I would like to thank VCare Foundation for giving this opportunity. And I'm really humbled to share the screen with Dr. Rajendra Gupta and you and entire VCare team. So yes, during the COVID times, we have all used technology and some of the other type. So we have during the COVID times, we had started Zoom consultations, teleconsultations, and that has really helped patients during those periods. So especially the follow-up of the patient, we used to have it on the Zoom, and which spared them the entire travel, their expenses, and many a times it was not possible because of the regulatory reasons also. Especially since Kolhapur is at the border of Karnataka and Maharashtra, so we have many patients coming from Karnataka to us. And because of the regulatory issues, the patients couldn't travel from Belgaum or outside the boundary from Karnataka into the Maharashtra. So at that point of time, we have used this technology in various aspects. And this teleconsultation is just one aspect. Just as Dr. Gupta just mentioned, that there are n number of other technological aspects that are being used in healthcare or cancer care, especially nowadays. So we are participating in one of the studies, one of the artificial intelligence based studies, in which an AI is being developed, which can red flag some oral cavity lesions. So if a patient just clicks the photograph of his oral cavity lesion, and the AI tool will help us to know whether it's suspicious, what are the chances of it converting into the malignancy. So such type of technology is also being used, and I think there is no limit to that. So this technological advances are here to stay with us, and we must use it in all aspects.
So, Dr. Gupta, coming back to you, when we talk about artificial intelligence and we talk about all these various technical things that are coming into being, do you think our patients who are not so savvy in terms of technical knowledge, who are not so savvy in terms of using a computer, or don't understand terms like artificial intelligence, what can be done for them?
So firstly, I'll add to where Parag left, maybe pick up the thread. So a week or so back, I was speaking to my friend who leads the telemedicine at Memorial Sloan Kettering Cancer Center in New York. And she was sharing with me that though she believes still in the doctor's touch, in a human interaction. But majority of the patients of the Memorial Sloan Catering Center do not want to come to hospital on a second visit. They are okay with the first time visit meeting a doctor. And the other side is doctors also not very keen to call the patients to the hospital. They say it just works phenomenally. So as an individual, she was very worried about this trend, but she said that's the reality today, that neither the patients want to come on a second visit, neither the doctors want to call the patient on a second visit. So technology has now become that level where you are substituting a face-to-face visit by a virtual visit. So that I'm talking of world's, the biggest reference center in terms of cancer care. Having said that, all of us always are kind of taken by these terms called artificial intelligence. And I'll ask Dr. Parag to give you a sense of how we have been using it. But Dr. Parag, have you ever used decision support tool in your practice of looking at symptoms and all?
To be very frank, no, not yet.
So like the up-to-dates of the world or the clinical.
Yeah, of course. Those, yes, of course. But not per se for a individual patient. I mean,
I agree.
Yeah.
So,
no, but I
go ahead.
I've seen that on the in fact MD Anderson website. There are risk category parameters. So if there is a patient of a CA breast and her relatives puts in some enters her data, her age, which relatives have been diagnosed with breast cancer and other contributory factors, then that AI tool will guide you and tell the risk of having breast cancer in that individual. So such type of tools are there, but I personally have not used them.
So, Vandaji, this is the reality that all of us are somehow, using an AI backed tool, not knowing that it is AI. So I would not say most of the doctors, but doctors who have access to products which are decision support systems are actually artificial intelligence systems. So this is where the doctors use it. On the other side, for the patients, there are a lot of things we use on the net, a lot of things we use in search actually have a tool or element of artificial intelligence. Some of these tools like health risk assessment, which Parag was detailing out, is that most of Indians should actually now look at health risk assessment. And this is something that we are developing at the Patients Union, where like if my mom had CA breast, if I put in the data, so genetical factors, my lifestyle in the city I live in, I should be able to find a risk score. So I think for patients and populations in general, the first level is health risk assessment of the predisposition to a disease. That's one. Those who have already got into having a disease, based on the complex multiple factors, they could actually arrive and saying, what could be the things that I should do? So I think there is a phenomenal opportunity for AI, but there is a caveat here that we should be very careful about. The biggest experiment ever done in AI was Watson, IBM Watson. And when it was launched, they tied up with major hospitals, including major cancer hospitals in India and across the world. But now it's as a commercial product being shut down. So the reason I say and I analyze is that, see, today we are used to using diagnosis or prescription based on our individual habits, right? Which is medical practice, which is experience. But just take the case if a doctor prescribes 3 antibiotics for fever, and if you feed in data of this for 12 or 15 years and create an AI tool out of it, what do you get? So I think till we get baseline data, which is based on the case management protocols being practiced, AI in clinical practice will not be that efficient. You will still need the clinical judgment of a doctor. But if we are able to get to a level of practice which ensures quality care, maybe 5-7 years of data, and AI tools are applied to it, I think this will bring in great help to get right diagnosis, which is a big challenge, and also get the most preferred or appropriate treatment. I'll give you a case here. A senior doctor of OCAD, Bombay, was not being able to diagnose for his problem. And this is a doctor from Bombay. It was a clinical decision support system, which was artificial intelligence driven, which was able to diagnose and save his life. So on terms of diagnosis, in terms of risk assessment, in terms of potential things that could be happening, I think AI will have a crucial role to play. And in life-threatening diseases like cancer, it will have, I think, a bigger role. not only on treatments, but also in terms of repurposing of drugs, which we saw during COVID. I think there is a phenomenal application of AI in cancer for patients and for providers both.
So, Dr. Watve, takes me back to ages, like when you were very, very small. And I remember there used to be the doctor coming home and seeing your pulse. And with that, he was able to tell you the disease and look after you and give you treatment and all that. So, of course, even now, many of our elders who tell us that, that was the best way of treatment. So to tell them that, you must have, you can meet a doctor online, do these things, how acceptable it is, especially since you are living in a village area surrounding by lots of small villages. Is it easy to convince them to take all the online thing, or they still feel that holding the hand is the most important thing?
No, a few of them do have a problem. They would like to visit and see in person, but if they have a face in front of them, then that's reassuring enough for them. So if you just send a message across to them that all your reports are okay and there's no need to worry and no need to follow up actually at the hospital, that may not be sometimes sufficient for them. But if you have actually a Zoom call and there is a face, a doctor talking to them, that's reassuring enough for them.
Okay, so that's how you spread out to all the nearby villages near your hospital in Kolhapur?
Yeah. So Zoom based conversations or a video call is the best way to do it. I mean, we tried just that calling up patients and our other counselors or other helpers, just telling them about their condition and giving them the treatment. But having a face-to-face conversation has a different touch to it.
And do you face networking issues and electricity issues and all that?
To be very frank, not really. The infrastructural growth has been phenomenal in this part of India, and a few hiccups always are there. But then on the majority of the times, no major challenges have been faced by us.
Which is very heartening to hear, because every time you keep hearing of electrical failures and networking issues and how do we cope with it and all that. So, Dr. Gupta, I've been telling you many times that we as patient organizations need to work together with all of you to be able to do something. And I think the one good thing that you have done, probably because of all the talks that we've had the International Patient Union meeting on the 6th of April. So what is it that you want to develop in it? What is the unique factor in it? Could you make us all a little more aware of the entire thing? And also we would like you to say whether it can be a collaborative effort, even from this support group's point of view.
Yeah. Firstly, thank you so much, Vandaji. It has been your inspiration, I would say, when I met you in one of the meetings, and the amount of work you have done for cancer patients. It is moving to see that how much change one can make, how many lives one can save. But as an institutionalized approach to other category of patients, I always felt that this was missing, and being very active on forums, and then joined the government. I always felt that doctors have Indian Medical Association, doctors have Federation of Family Physicians of India, they have FOXY, I mean, name a specialty, they have a organization. So doctors are organized, nursing is organized, pharma industry has IPA, OPPI, so medical devices have IMED, software companies have NASCOM, but we all work for the patient. Where is he? Where is she? You don't find them organized. I worked between 2016 and 2018 as advisor to the Union Health Minister. I never met a patient group. It was so sad. I mean, we work for the patient. Patients are not organized. So what do we do for them? So this was a thought. In 2014, I actually announced that I will be setting up International Patients Union, but then I joined the government, years passed by. But there was always a feeling that, I don't think that I'm doing enough for healthcare, because if you don't get patients organized, we will all have a supply driven system. The industry will get what they have, patients will not get what they need. So there's a huge gap because they are not a force at all. And these kind of things require a lot of resources. You're coming all the way from Bombay to deliver a talk. It's a big resource. And we will not be able to afford, but thankfully with the support of people like you, we thought, that it is time for us to get patients to hold a conference for themselves, talk about what they need. So this is first time I think ever in the country where we had a patients conference, started with the patients talk. So like 7 patients telling what they felt, what was needed, and that moved a lot of people. In fact, we got a lot of emails and calls post that this is much needed. But the vision, if you ask me, is not hosting a conference. As we have already launched an Android app, we will be launching an iOS app. The whole idea is patients based on disease group should be on a platform talking among themselves how to manage a disease. Because if Dr. Parag sees a patient, he cannot see a patient every other day, and the problems or maybe questions keep popping up from morning to afternoon to evening. The best thing is if they can be on an app talking to other patients, how do you manage if this happens, how do you, so his life becomes easier. See, in India, specialist is a scarce resource. You have to make sure they are used at the most appropriate time rather than for recurrent routine things which can be solved by technology. In this, the whole idea is that we use artificial intelligence, we use generative AI to let people find solutions to their problems, which does not require a clinical expertise. That's the first thing. Second thing is that today, if policymakers want to interface with patients, when I was writing the national health policy, I had no access to any patient group to bounce off ideas. All we had was doctors, industry people. I felt so, incomplete in terms of problem. Luckily, I had a family of all patients type in my immediate family, so I knew them. But now, as a structured approach for patients union, we could actually bounce off a policy to them and say, hey, this is what we are coming. What can we do on this? Is it appropriate? Do you want to give inputs on this? Same we can do with the industry interfacing with patients. Why does Cetapin have 15 tablets to a strip, Amiral has 30, and Glucobay has 10? When a diabetic takes all 3 of them, and the proportions are typically, having 1 or 2 tablets a day. So would industry want to sell more tablets in that? That's why they do it. So there are multiple things that we could solve as a group. And the whole idea is end of the year, we'll be probably the largest group in the country. And by next year would be substantial influencer, in bringing the right change bottom up, being a force that government cannot ignore. So our goal is to do that. And then the next level would be to push towards standardization of healthcare. I mean, if patients start rating a doctor based on verified patients, I don't think they would need to market themselves. If people say that you have an issue, he's the onco-surgeon, Dr. Parag Watve, whom you should go and meet. Why does it require to go to people? Or if I don't do well, they say, I think you can avoid. Doesn't make sense. So eventually we'll get into that for verified users, but we'll be very careful on that because we do not want misuse of the technology platform by vested interest. So we have a huge challenge on there. But I think as patients union will be a big leveler in terms of moving towards a quality which is outcome driven and patients being able to solve their problems through discussions. And we will help them find solutions. That's our end game, that let's find, like I had a cancer patient from Mau near Varanasi, called up and said, "Mujhe AIMS mein aap kara do." I said, "पर AIMS में क्यों आना? हमने इतना बड़ा कैंसर हॉस्पिटल खोला है वाराणसी में, अब वहां पे चले जाओ बगल में आपके." They didn't know that. So information is missing, which is basic. Then I called up the doctor. I said, meet them. They need to not come to AIMS. For everything, you don't need to come to AIMS or Tata Memorial. There is a hospital. We have opened so many cancer hospitals across the country. So I think as patients union, we need to create that awareness also. So our goal is give them the information, the right information, help them by interacting among themselves or doctors. We are also onboarding doctors who would like to volunteer. So if you look at the app right now, people are asking questions, doctors are answering questions, which does not require clinical validation, like they are basic questions. So we are talking to a group right now to onboard 300 doctors who would like to volunteer to make sure that people don't just go working with quacks or going to a chemist for smallest thing, but get the right advice. So our goal is, and I think there are well-meaning doctors. There are doctors who want to give back to society, like Dr. Parag has gone to Kolhapur. Ideally, he has the intent inside that I want to serve people. I want to serve people in need in towns where doctors you won't get a cancer specialist there. Now he is there. So same way on an app, I could get you any part of this country. You don't need to be in a big hospital or a big city. So that's our goal.
So 3 questions that have come up from your conversation. One is the multiple languages that we have in our country. How can you manage that? Secondly, the people who are using your app, what is their, social level? I mean, I don't want to put financial level, but their social level of understanding of the whole thing. That is the second thing. And the third thing is that are you also planning to get in touch with the other support groups of other diseases and get them together so that, you can hear from them the challenges that the patients have, because it may not be possible for you to meet all the patients, but the people from various support groups have met several patients, and they would probably have a knowledge of people who are in the below poverty line and whatever the challenges they face for everything else. So have you thought of those things, Dr. Gupta?
Very important point. When we start small, so the obvious thing on an app is start with English, which a small portion of Indian population knows. We started with English, we are adding Hindi, but we had a meeting last week to put this in 16 languages. Because some states you would expect Hindi or English, it will be their local language. So our goal is to add as many languages as possible. Since this is bootstrapped and funded, so we have to be very careful how fast we can move. The other issue that we are working on is security of their data, privacy. So we are also looking at making it secure enough, because these are patients. We don't want them to be exposed. So language barrier, I think we will be able to address because technology allows us. There will be some investments on that, but we hope we will be able to do that. On the social level, I think this is a segment we got to learn as we dive into it. We don't know. So this is first time where we're getting patients. With the first time we are trying to get patients onboarded. So that leads me to your third one, where we could work with groups like yours to directly reach out, because individual reach out for a venture like this, the cost of reaching out is going to be unbearable. I mean, like you would have million people. I mean, for us, it is good to onboard those people straight on the platform and let them be saying, okay, in the cancer group, please carry on the discussions you want. So the best way for us is to work with other groups. So we are looking at diabetes, neurology, oncology. So various groups of patients talking on their issues. Like, we find females with epilepsy at a very young age. You heard that lady there. We got another patient who was being forced to undergo an operation to get married. She didn't want to. But I wish this kind of app could create a support group among themselves so that they could take right informed decisions. And working with groups will help us in our journey faster. That's the way forward we're looking.
Okay. So, Dr. Watve, I'm sure you had not heard about this setup that Dr. Gupta has started. And what do you think about it? Do you think your patients will benefit from it, or is there some suggestion that you have about it?
Yeah, no, of course, it's a very good initiative. It's a wonderful initiative, and of course, I've heard about it. I mean, there are small groups already working in pockets. So we have a laryngectomy club, or a breast cancer patients meet. So things like that happen in pocket. But if all that knowledge, or all entire their knowledge comes together in the form of an app, or they can be together there, then that will be very wonderful. Patients have a very unique solutions to many problems which we doctors even don't think about. So they will have different kind of problems and very unique and different answers or solutions to them. So having them together and just giving them a platform to interact is definitely going to help them improve their quality of life in and I mean multiple of times.
Dr. Parag, before I move on, there's a question for you. How much are the patients whom you meet and treat involved in making decisions about their own treatment and care?
There are 2-3 categories of patients. So one is that I'm going to face everything on my own. So that person accepts everything and is ready to accept whatever treatment that we offer to have the best possible outcome. But there are the other end is that they are very scared, and they even are afraid to enter the cabin. So they will just come, they will have the consultation, I'm allowed to examine them but not to disclose anything to them, and the patient will sit outside, then I have to discuss all the options with the relatives, and then the relatives sometimes take a call on behalf of the patients. So that those two extremes are there, and there are some individuals who lie in between somewhere. So yeah, we do get all variety of patients, but as far as possible, our aim, our I prefer to talk directly to the patient so that he is aware that what he is going to go through, what kind of problems is he should anticipate, and if at all he wants to make some provisions for that, then he should do it prior hand.
Yeah. But the whole thing is that the family thinks they are being very protective and they don't want the patient to know. And also, I think there's the fear of stigma. I'm sure you
Yeah.
must have seen a lot of it in your practice, especially in tier 2 cities. It must be even more. I mean, it's even in cities like Bombay, but I'm sure it must be more in Kolhapur.
Yeah, the stigma is there, but once in a while we come across an individual who is ready to stand up. So we had one teacher so who had a oral cancer because of tobacco, and then when he resumed his duties, he started an awareness campaign amongst his students to make them aware about the ill effects of tobacco. So if one person stands out like that, then that nullifies 100 of other patients who are stigmatized by that. So one person standing up, that sort of promotes two other to stand up and be open in the society.
Dr. Gupta, since you work so closely with the government of India, I know the government has come out with various schemes. Some are very good, but there are a lot of lacunas in those schemes. What do you feel about it? Do you suggest to them, or do you know about the lacunas? How does it work out? Because we find a lot of things which are missing or can be added on, or probably it's too early to say. Maybe it'll work out after a couple of years. What is your take on it?
Kandaji, if you allow, can I make a comment on your previous question that you made to Parag? Because
Okay.
I had an experience of a cancer patient in the family.
Sure.
So I'll tell you, you raised a very sensitive point, I will say, on the stigma behind the disease. So my mother was, a professor in chemistry and did her PhD in nuclear chemistry. And when she got cancer, T4 stage, so we were like, as kids, actually, we are still studying in graduation. So, and what we had seen, and this is very interesting to know that, what happens in the mind of a patient's family. I think he has already said that as doctors, we don't tell the patient directly. Now, I could sense what he meant, because when my mom was wheeled into for a fracture, which ended up being a pathological fracture. So my elder brother told the doctor, "Inka chest bhi dekh lo, isme lump hai." And that's where when they did the biopsy, it was T4 CA breast. So now for us, it was that she used to help a lot of patients, because we were just outside the Institute of Medical Sciences. We stay in the same campus. And we had seen that any cancer patient who went to that BHU hospital, Institute of Medical Sciences, died in 15 days, 7 days, maximum 6 months. So we literally got shit scared about she has T4 stage cancer. The first question we asked the doctor, how long will she live? 6 months at max. So we requested the doctor, and now we believe that it could have been a terrible thing to do. Make 2 files. One file for her fracture, which should be ordinary fracture, and one file for her CA breast, and keep both of them separate. If any doctor wants to see besides you, because she was a popular figure in BHU, people would like to see what is going on, and you know what happens. Show them the fracture file, but the CA file should be in the drawer. So no one knew she had CA. All thought she was being treated for fracture, which went on. She survived for a year and a half though. We didn't even tell her parents, who were alive at that time. No one except, 3 brothers and a sister knew about it. The challenge is the other part. I think this is where we have to play a bigger role with the societies. People have a habit of going and discussing with a cancer patient, oh, it is so bad, we know it means this. So you demotivate and demoralize the patient and break their strength, rather than giving them, which you should not talk to them as a cancer patient. So the reason is not just stigma, it's fear. Is the fear of someone raising up the same issue for which you are. The difference is that people think patient is dying with disease, but the fact is patient is living with the disease. Now you don't want to go and talk over and over again and again saying, oh, I know it's cancer, but this can happen. You should take this. This person died like this. So you build up on the psyche of the patient, which becomes really difficult to live. So other people have to understand, if there is a cancer patient, what is the guideline? How do you talk to them, or do you talk to them at all? So I think stigma has more dimensions here than just stigma. It's the fear of raising the fears, making the life little difficult. So we have seen that in the family. So I think that's a bigger issue for cancer patients, why they are not told directly or why other members don't leak this thing out. Now, having said that, coming to the policy, I agree that policies do have, loopholes, sometimes very serious. And that's why if you look up the last paragraph of the National Health Policy, it talks about monitoring evaluation. It talks about community-based monitoring. So one of the things we are going to do at Patients Union is also get patient perspective on what's the impact of the government program. So my role as a policymaker came from what I'm going to tell you, and this is important for all of us, that I don't come from a political family. I didn't have those connections in policymaking, but I felt there was gaps. So I started writing to people, look, this is not something we should do. I wrote to the health secretary that we should come up with a health policy. We are spending so much in 11th and 12th 5-year plan. And eventually I thought people started calling after it. In Ghulam Nabi Azad used to read my mails, and if he missed out, he would ask Rajendra Gupta to say, please get from Ravi, and if he can resend that email. So I think all of us have to really read the document and then comment on it. And policymakers like good inputs because that's their weakness. They will ask a bureaucrat to write. Bureaucrat will write what his friends tell them. They will not go and open out everything. Then they put the policy in public domain. Very few people know. Few vested groups will comment on that, and that will become a policy. So I think policy requires a lot of involvement and engagement of people like you who work with patients, understand their problems. So like we had this meeting in ICMR yesterday on assisted living technology. You are not there, being the person, I think, supporting the largest number of cancer patients. But why you should be known through someone to be invited to that? Ideally, it should have been. So if you're not in Delhi, you're not in the policy circles. So I think the government has to open up to let those NGOs or even patient groups come in as a part of the system. And the other side is the patient group should also be vigilant enough to say, oh, there's a policy document out, we need to send our comments. So, and comments are taken seriously, that I can assure you. In National Health Policy, we had thousands of comments. We sifted through all of them, segregated them, and incorporated them. So I think it's a two-way process. Government needs to open up and public needs to be proactive. I don't think people have read even the 32-page document of the National Health Policy. So if people don't read and they start asking on things which are already mentioned, so it gives a bad impression, but it's a two-way process. We don't teach National Health Policy in public health. We should actually make it mandatory. People read it, get thinking about it, and then start working towards if they find there is a gap. Like after COVID, a lot of things need to change. Is there a way we have looked at it? Now there is a controversy going on health drinks. Why are people not rising until now? If one health drink has 70% sugar, why it is that one person has to raise the issue? So where is the collective patient group that so far has not raised it? So I think this requires more two-way process, government engaging with people and people engaging with the government, not one-off, but on a regular basis.
Yeah, you're so true. I mean, it's absolutely right that, most times we also shy away thinking that the government may not do anything, and we don't. I mean, we presume that the government is not going to do anything, and so we don't write or we don't work on it. And I think it's a responsibility for the support groups. So while you were sharing your personal experiences, I thought I should also put in something. One was that, my chemo used to happen every alternate Friday. And every Thursday before my chemotherapy, somebody would ring me up and tell me that, how somebody had died of chemotherapy and how it was very bad and how, because of chemotherapy, this thing happens and that thing happens and all that. So going on the Friday morning for my chemotherapy was like a trauma for me. And it was always whether I'm going to come back alive or not, because anything can happen, It was really a feeling of being taken to a slaughterhouse and not knowing whether I'll come back alive or not. And a stage came when after 2 or 3 chemos, I stopped taking calls on Thursdays because I said, I don't want to talk to people. And Then after a few weeks, I got a little more courage and I would ask them that, did you have chemotherapy? And they said, no. I said, then I don't want to talk to you because you haven't had chemotherapy. So it was, but I don't know how many people have that type of courage to say that, And also when we were starting We Care, my mother-in-law was with me and she was very affectionate. So and I have a daughter and her concern was, you are talking so openly about your cancer. I hope there won't be a problem in the marriage of your daughter because everybody would want to, shy away from the fact that she's your daughter and that you had cancer and all that. And my reply to her was that I don't care if they don't marry her because I have cancer, because getting married is not important, but having people who can think progressively, and I don't want to hide that I had cancer or something, and that was important. So till the time, I mean, I said all that to my mother-in-law, but I can assure you that till the time she got married, this fear was always in my mind that, what if doesn't happen, or what if she has a problem or whatever it is. And even when they agreed to get her married to their son, my my conversation with them was that, I want you to know that I've had cancer. I've been treated, and I hope you know about it. And so, if you still want to think, please take a day and think about it. So their immediate reaction was, it doesn't matter whether you had cancer or not, because even after marriage, something can happen. So, I mean, that was something which goes on in your mind. So I can imagine this stigma which people have, especially when, they are from the villages, when they are not so educated. I mean, that's not the right word to say, but maybe not so aware of everything. And so the problems do come up. So now a question to both of you. Maybe we can start with Dr. Parag first. What do you think is the important in the future of cancer care? With, health literacy, patient centricity, financial toxicity, how will we move around and what will we do about it?
So the answer is manifold. I mean, the cancer treatment or the entire cancer journey begins with creating awareness, having preventive measures, early detection, treatment options, rehabilitation, and then it goes on to have a palliative care. So in all those aspects, the technology is going to help us in some or the other way to bridge that gap. So as we discussed, the many AI tools are being developed to have to create awareness and for the early detection part of it. As I said, the AI-based tool which will capture a photograph of a lesion and red flag it whether it's going to be malignant or not. Also, there are again the technology is going to help us in bringing the pathologists to the doorsteps of the patients. So many a times what happens is patients will have to come to a metro city or at least a tier 2 city to get a biopsy and to get a diagnosis of their lesion. So all those things can now be managed at their hometown, where the processing and other parts can be done there, and those captured images can be transferred to a pathologist for the reporting. Treatment aspects, many things again, robotic surgery, as I said, the AI based decision tools. Now rehabilitation is coming up, so many prosthetic options. We have 3D printers, we have different models to show patients how their surgery is going to actually look like, and how the reconstruction or the rehabilitation is going to take place. So all those things, the future looks really good with all this technology around us.
So tell me something, has any of your patient not done the treatment because of lack of funds, or because of lack of support, and because of lack of anything that they might have gone through? Have you had a challenge with any one patient? Would you like to share the story?
So yeah, lack of funds, it happens. So as of now, majority of the government schemes are for certain poor socioeconomic class of patients, and what we call here is a white ration card holders. They are not eligible, they were not eligible for to avail the scheme. And somehow one patient we had, he had a pan stall. So he himself used to sell tobacco and consume tobacco for the entire day. Unfortunately, he had that white ration card, and he was not eligible to have those eligible for that government scheme. So he had a lot of challenge in raising that fund. Somehow he managed to borrow some money from his friends, from relatives. Some NGOs came to help. So yeah, once in a while this thing happens, that patients, although are actually poor, they because of some minor regulatory issue, the ration card issue or the other issue, they are not eligible for the scheme. So yes, this fund problem does happen once in a while.
Dr. Gupta, the same question to you. Uh, what do you think is the importance of, I mean, I'll say cancer care, it can be any disease care, because I'm sure the same challenges are faced by everybody, about health literacy, patient centricity, and financial toxicity.
Yeah, I think it is, if you really look at the occurrence of these diseases, which is chronic, I think now it is not about 10 or 15%, it is about 100% of the families. Every family has a member either predisposed to a chronic disease or having a patient of chronic disease. With that being said, now what we have to work is not primary prevention, it's secondary prevention, I call it. So I think that's a word you will rarely find being used. So, and we tried this, we did a health risk assessment some decade more back, in Jaipur with 2000 people, checked them across disease profiles, and we found 20% plus had those diseases they didn't know. In fact, a classic case of an educated lady, my mom, having cancer, she didn't know. So I think system wise, we have to address. See, having public awareness goes to a point of no return. I mean, it has become so consumption driven, like people are not even bothered about those ads. They will go and take a break. So I think those things aren't working. Let's be realistic about it. We are carpet bombing those campaigns and spending crores of rupees. So what we need to do is make it system driven. The ideal thing would be to move to a preemptive model of care, which is in the national health policy. From school level, start the process. So right at teenage, start screening people. When we created this women's health guideline, so we looked at a lot of things that could be caught on very early on if there were like these are non-invasive screenings. So I think we need to bring them as a part of the system. Just giving an academic report card without a health report card does no good thing. Because if you did a health risk assessment, you could say, look, you have this dental problem, you have this problem, let's treat them. And the other thing is, let's not scare people. A lot of people have that issue that if I have cancer, I'm not going to survive. Actually not. If you got it on time, you're going to live a normal life. So that scare part has to go and it'll take time, but then you got to bring in a system driven approach. Awareness to a point has not helped us, I'll say. Few cases would have been caught, but majority are caught in a very late stage. When your life daily routine gets impacted, you go to a doctor. That's too late in the day. So I think it has to be, every corporate should invest in screening their employees. Every school should make sure the students are screened. And rest, the government has such a good machinery that they should say, if you want to use certain level of service of the government, produce a medical screening certificate. At least I know people will circumvent that, but we'll be able to catch people, get them on time and treat them. And then of course comes the issue of affordability. I would still say that path we are taking of privatizing healthcare is not a great one. We need to still move to investing in public health infrastructure, which has been the focus of the national health policy, strengthen it. For poor, you got to provide, but I don't see a rich man not paying in aims and getting it free. So it should, as I think those who read the national health policy is written, it is based on the ability to pay. So if a rich person goes to aims, let him pay market rates. So I'll be able to cross subsidize aims and open it all across the country. So I think this, as I think Parag has very clearly said, it has multiple dimensions, but that awareness to a point has not helped. Cigarettes have 80% of their cover with cancer, but what is happening? So if you take cigarettes, no insurance for you, no government scheme for you, then people will think about it. No government job, like I think Rajasthan did that fantastic thing. So we got to take, now incentives are not working, start with disincentives. So I think you need to think differently. Otherwise, India has already become a populous country in the world. We are 142 crores by mid of this year. I don't think we are going anywhere with the old approach of health. We're going to have a serious problem.
So, Dr. Gupta, another problem that comes is the insurance policies. I'm sure both of you are aware that, insurance policy, if you are healthy, you can get it. But once you have cancer, you can't get any insurance. One company has started something which is like, you can get an insurance even if you have cancer, but it becomes valid only after 3 years. And also the same cancer it should not be the same cancer. So there are a lot of, things which are going wrong, according to me, in the insurance sector. They can have a higher premium for people who have had cancer, but at least, especially for children, when they have cancer at a young age, and then they don't get insurance policy for the rest of their lives. Is it being fair to them? Can we do something about it?
So that, fundamentally questions the very basis of it. So what is insurance? So insurance means that for a population of this size, you pay a small premium and you cover the risk. So insurance is not assurance. There are two words. Like coverage is not usage. Today, 55 crore people have coverage of PMJY for 5 lakhs, but that's not utilization. So we need to get to the fundamental premise of how to be managed. So if we were to really deliver, there are 2-3 paths, and I'm sure there are multiple models. When I look at it, like each one of us, whatever we are earning, a small portion of our salaries could get into a health saving account. God forbid something happens, it is covered. That's one. The second thing is health management organization. So suppose a district like in Thane, to the district hospital or the nodal hospital of that, give them a lump sum and say, manage the health of your populations. So whether it is screening, treatment, whatever. So they will have an incentive to keep the health indicators in check. And you get a fixed amount. If you save, you go back and invest. So I think India as a country should try to move away from insurance model, because my research in this area says when you put insurance, healthcare becomes expensive by 3 times. Because the patient is asked, वरना जी आपके पास इंश्योरेंस है, अच्छा आप काउंसलर के पास बैठ जाइए. Then they will have a different battery of tests, they will have a different level of surgeries. So insurance has always led to increasing the cost of care, not improving the quality of care. So
in fact, I have heard that, if you are insured, and if it is like cash or something which the company pays for it immediately, there's a difference in the cost if the cash is being paid and if it is coming by check subsequently. So insurance companies also have this tie up with the hospital, so to say, about the thing. Dr. Parag, what is your take on, what Dr. Gupta just mentioned about, this?
No, true, absolutely. Yeah, so absolutely true. So even in our hospital, the cost of the bill of a person who has undergone a treatment in an insurance under some cover of insurance, and if you compare it with somebody who has done it under a cash, who has done it by paying via cash, then it differs. So there is some difference in the bill. So some part of it also goes towards we have to manage a department just to reimburse that money recover that money from the insurance companies. So that is also a challenging task. So that flow, that managing that department, that also adds to the cost. Plus insurance companies have a certain claim that they will give only 10%. The 10% discount is by default on all the bills. So all those things add up, and they eventually, who is paying for that? Our patient. So patient's premium goes up in doing that. So a good way to do it would be, as I was saying, that have your individual health savings account, and you deposit a chunk of money regularly in that. And if at all, unfortunately, you need that, then you have that cash at hand.
Yeah. And I think that's also a good idea that, if you are smoking, then de-incentivize people that if you are smoking, then you are not liable for insurance.
Absolutely.
If you're smoking, then maybe government jobs can't be given to you or something like that. So that people become a little more, conscious about what they should not be doing rather than what they are doing and all that.
True. So that same thing should also apply for the government insurances as well. So the private insurances now do have that if you are a tobacco consumer or a cigarette consumer and then you have a cancer, then your claim gets rejected. You are not eligible for that. But it's not the same with the government insurances.
Yeah. But say in your hospital, do you have Ayushman, Dr.?
Yeah.
And is it easy? And do you all your patients get the Ayushman medicines through Ayushman immediately?
So majority of it, yeah.
Yeah, because we find a lot of patients, not getting the medicine that they want, especially if they're looking for molecular medicines.
True. So I would say that it has covered the 80% of the chunk. So the maximum chunk has been covered under Ayushman or Rajiv Gandhi, Jyotiba Phule. Now the Maharashtra state has a Mahatma Jyotiba Phule Jana Arogya Yojana.
Yeah.
80% of the population has been covered and 80% of the diseases have been covered. So there are going to be some sort of outliers who will need some molecular tests on the diagnostic side, or who will need some molecular treatment and immunotherapy. So that is surely not covered under the scheme as of now.
Well, we have a lot of things to ask and talk about, but we also are conscious of the time. So one last message from each one of you, one last thing that you will, which you think that that challenge or change should be addressed. Can we start with Dr. Watve and then go to Dr. Gupta?
As I was saying, that the patients need that human touch. They need to see a face of a doctor, and that gives them reassurance. So having said all about this digitalization and technology, somewhere I feel that down the line we should not lose that touch in this digitalization. So a doctor, I feel, plays sort of 2-3 roles. One is to give a scientifically correct treatment to that patient. Second is to provide empathy to that patient, and third is to sort of give a practical solution to his problems. Sometimes the scientifically correct treatment is not good for that patient because of some other aspects, some social aspects, his personal health aspects. So to manage that and give that balance to all those things is the role of the doctor. And somewhere I'm afraid that this digitalization or over digitalization may lose that personal touch which many of the patients need.
And I think our 1.42 billion population will also further add to the problem that the doctor does not have the time to look at the patient's face or know his name or know more about him, because now the excuse is always that we have such a huge population of patients. So I hope you are doing something about it. One look from the doctor to the patient is extremely important. And Dr. Gupta, how about you?
So I think in field of healthcare, the one word that stands out for me is responsibility. I think as patients, they have to be responsible to be communicating everything frankly to their doctor or the nurse or the pharmacist, not hide anything, and to say it frankly. That's one. Being responsible, being also adhering to the regimen that is prescribed and not trying to cut corners on that. So I think patients' duty and doctors' responsibility go hand in hand. So we cannot have a one-way system. It's a serious thing. I think we have done a lot of studies. Well, there are excellent doctors who still keep the faith in the system alive. That's why doctors are still called next to God. That position has not changed. But there are bad apples too. They need to, even I understand that the average time a doctor spends with a patient in India is 2 minutes, in Pakistan is 60 seconds, and in Bangladesh, Afghanistan is 48 seconds. But just a smiling look with the patient takes half of the worry off of them. Holding the hand and talking, don't worry, we are there with you, is just good enough. So I think that makes a big difference. That's why we started this campaign, the talking helps healing. I know time is less, but then people will have to understand whatever time you have, make the best use. Technology can take care of your prescription. Technology can take care of diagnosis. It cannot take care of the assurance that the doctor is holding a hand and smiling gives. I think eventually all doctors will have to ride on technology, but then they are riding on technology. So their behavior with the patients will count a lot. How they treat, how empathetic they are. It is not that doctors don't want to, but somehow their workload shows up on their interaction, and which has a telling tale on the treatment. A patient does not want to go to a doctor. One patient told me, sir, मारने के सिवाय सब कुछ कर दिया doctor. Just imagine. What do you feel about it? So I think all of us have to be responsible as patients, as doctors. So for the one word for me, for everyone is be responsible in whatever you do.
Yeah, and after my saying that, the doctors are only looking at the file and not looking at the patient, the good and heartening point is that, we don't get many cases of bad treatment or wrong diagnosis or wrong treatment. So to that, I must say that I would like to congratulate our doctors for all the efforts that they make to make sure that the treatment is correct, so that also shows their competence and their interest. It's just that from the patient's point of view, we feel that if they were to, to say that the patient should be able to say that, this doctor is treating me or something like that, but that recognition gets missed out. So thank you very much on behalf of WeCare. And this was a new initiative that we have taken up because we've been, last 2-3 years, all our webinars have been based on the treatment aspect, whether it was chemotherapy, diet, radiation, palliative care, prevention, all those topics, BMT. So this was the first time that we thought we should go beyond the treatment aspect of it. And so we took up this topic of digital health and all that, so that, we start talking and letting people know and people understand. And I'm so happy that Dr. Rajendra Gupta and Dr. Parag joined us in our efforts. And we may continue to bother you because we are planning to take up new topics like that. So thank you very much, Dr. Parag, and thank you very much, Dr. Gupta.
Thanks for having us and a great initiative. I salute you for your efforts.
Thank you.
Thank you so much.
Thank you.
Thank you.